Okay, it's 10 o'clock. Let's make a start. Welcome everybody to this meeting of the Worcestershire Acute Hospitals NHS Trust board in public. We've got a variety of things on the agenda this morning. Can I welcome particularly to this meeting Joe Ringshall from Health Watch, welcome, and also Anna Sturks and Avril Adams, who are going to talk to us in a bit about a patient story. The meeting itself today is shortened, and I think it's just worth me saying why that is and something about it, in the sense that we are still, as a healthcare organisation, under enormous pressure from both the overall demand for healthcare at the moment, our attempts to reduce the backlog that's built up over the last 18 months, but also the continuing increase in the number of patients that we are admitting with COVID. I don't think any of us who've been in the healthcare system for any kind of years, and I've been associated for 40 years, has ever seen anything like we're seeing in terms of demand and pressure on the service that we have at the moment. And it's absolutely clear from me, and I guess the whole board, that we offer our particular thanks to our staff in these circumstances, who are doing absolutely heroic work in order to help and support our patients at this very, very difficult time. So thanks to all the staff for doing it. And I would also thank Matthew and the executive team. One of the reasons that we've shortened the board meeting really is we're attempting to reduce the burden on the executive team, because they've got an enormous job to do in terms of steering this organisation through very, very difficult circumstances. So thanks very much for the executive team. We really do appreciate what you're doing over and above what you might expect of a team at this time. So thank you very much. So the board meeting itself hopefully is to be shortened. We're just going to focus on those issues we really need to focus on. But as part of that, we start every meeting with either a staff or a patient story, where people who directly work with patients or are patients can talk to us about the service that they do, both the strengths and weaknesses, and perhaps in sometimes asking us what we as a board can do extra to help them. Not only is it important for us to do this, but it's important at the beginning of any meeting that we have to kind of ground ourselves in the reality of working in the NHS in 2022. So without further ado, can I pass us over to Paula, who I think is going to introduce the item. Paula.
Thank you, Chair. And welcome, as you've already said, to Avril and to Anna. So this is about the support initiative, which is an excellent campaign. And this is to raise the profile of end-of-life care and ensure that the end-of-life care is everyone's business. And this was initiated at Leeds Teaching Hospitals originally. And what we've got is a short video so that you can see what the actual support mnemonic actually states, and then there'll be a little chat with Avril afterwards and any questions. So without further ado, we'll go straight into the video. Thank you.
I'm Matthew Hopkins, and I'm Chief Executive of Worcestershire Acute Hospitals. In our hospitals, we are committed to high quality, supportive, coordinated and individualised care for patients and those important to them at the end of life. We recognise that supporting families and carers for those at the end of life is important. We firmly believe that end-of-life care is everyone's business, and all staff in all roles play a part in putting patients first by offering holistic care to our patients in the last stages of their life through extending our support to their families and loved ones. I hope watching this video will help during this difficult time.
We support We support. Hello, I'm Leslie and this is Aero the therapy dog. We volunteer at Worcestershire Acute Hospitals and we're here to support patients and those important to them at the end of life. I support. I'm Sharon, I'm a healthcare assistant. I recognise that worrying about car parking fees at this time can be upsetting. I support by ensuring relatives know how to access parking concessions that are available. I support. Hello, I am Gemma and I am a ward housekeeper. I recognise that visiting someone who is dying can be an emotionally and physically exhausting time. I support by informing relatives and loved ones about the quiet spaces that are available for them to take a rest from the bedside, including outside spaces and our carers room on both hospital sites. I support. Hello, I am Sharon. I'm a ward housekeeper. I support by ensuring those visiting patients at the end of life are offered hot drinks, feel welcome and cared for in our hospitals, and that my colleagues feel empowered to do the same.
I support. Hello, I'm Nikki Heron and I'm the clinical lead for the palliative care team. Our hospital specialist palliative care team provides advice and support for patients with advanced life-limiting illness and their families and carers 7 days a week. We also strive to ensure we raise the profile of end-of-life care in our hospitals and empower staff at all levels to deliver high-quality, compassionate care to our patients and those important to them at the end of life.
I support. I'm Avril, lead for palliative and end-of-life care. The support project here at Worcestershire Acute Hospital Trust aims to act as a reminder to staff and share with relatives and loved ones the small practical things we can do to further support them at the most distressing of times. We know these small kindnesses, given with compassion, can make a difference.
I support. Hello, my name is Vandana Dubey and I'm a ward manager. I recognize that sitting at the bedside for long periods on a hospital chair can be very uncomfortable for visitors. I support these families by checking in regularly, offering our reclining carers chair and ensuring comfort for them at the bedside.
I support. My name is Tess and I'm an end-of-life care facilitator. Here at Worcestershire Acute Hospital Trust, we listen, we learn and we lead. And we know from shared experiences and feedback gained through bereavement surveys that access to written information about what to expect at this stage of life is helpful to visiting loved ones. This information is available and accessible in our relatives areas and on the wards for those who wish to read it.
I support. Hello, my name is Paula and I am the Chief Nurse for Worcestershire Acute Hospital Trust. We truly hope that through highlighting the small, practical things we can do, we'll offer compassion, understanding and kindness to relatives and loved ones visiting those receiving end-of-life care in our acute hospitals. Thank you. We're just going to pass over to Avril now, who's going to talk about how this came about through families' comments back and answer to the bereavement questionnaire. So Avril, over to you.
Thank you, and thank you for the invite this morning. So as indicated, Voices Bereavement surveys are collated and returned to us so that we can get feedback about what we're doing right, but also what we can improve on. And one of the things that was highlighted was, especially on the Worcester site, that there was no space or room for carers to be. So we pursued that, and we've been allocated a room in Larkspur probably about a year and a half ago, and we've started and nearly completed that room with charitable funds, support from the community, and also a lot of support from our colleagues within the trust. That is near completion. Obviously, COVID has paused a lot of things for a lot of people, including that support project. Alongside that, in terms of support, it's really an umbrella project. So we have over 200 care packs that provide very basic toiletries for people who may have been called into hospital, spending time at the bedside and don't have anything themselves. So we've got those care packs, which are really important and very useful. We've also, in terms of that legacy work, started to look at Hessian bags in terms of provision for belongings of those people who have died within the hospital, as opposed to the plastic bags. It's also initiated looking at mouth care and how we can improve that, and the TASTE projects alongside speech and language therapy. And we've also re-looked and re-edited our bereavement survey so that when support launches in its totalness, we can directly look at the changes we've made and the impact so that we can get really tangible feedback. And comms have been really brilliant in supporting us, especially with that video, which we're really proud of, in terms of moving this forward, but also sharing across the trust and engaging the staff, because they are essential to providing that support.
Thanks, Avril. Avril, do you just want to mention the room also at the Alex? With regards to what that room, because Gemma was on the video and Gemma has done a sterling job at the Alex getting the room ready, and I opened it officially on Friday, and it is beautiful.
Excellent. It is great. So the Stephen Bailey Suite has been at the end of Ward 12 for a little period of time. It's had a brilliant upgrade, which you've mentioned, and has been opened. And we know from the feedback that that room, which is not dissimilar to the Swan rooms that Shrewsbury Trust have, it is a very lovely, calm space for families to be together with their loved ones at the end of life. And they have got chairs that fold down into beds. They've also got access to shower rooms on the same floor. So it's, like we said, it's all those very small but highly important things that impact at that time. But what we know as well is how we care and the care we provide and the support we provide also impacts in terms of that bereavement process later on for those who are still here.
Yeah, absolutely. It is beautiful what she's done. So I do thank Gemma, and I will be sending her a thank you today. Okay, is Alice on, Avril, or is...
I'm afraid Alice has got COVID and is poorly, so
right.
I'm afraid.
Okay, so Chair, back to you then for questions.
Okay, thanks very much. I mean, a fantastic initiative, absolutely no doubt about that, and a very one that's really required. I know that, I mean, in lots of ways, we don't necessarily want everyone who's got to end of life to be associated with the hospital. You know, we need to obviously support people at home and all this, but when they do come in, it's those small things, I think, that make the difference to carers and the patients themselves. Can I pass it over then to Anita?
Thanks, Chair, and thank you, Avril and team. It's lovely to hear about this great work. I had one question, which is, do we have any special ways of collecting feedback from carers and families? Obviously, this is a particularly sensitive group, and therefore we have to do it very carefully. But how do we learn what we could be doing better?
So in terms of the Voices bereavement questionnaires, they were paused during COVID, but there are annual and quarterly reports from Voices, which is a national bereavement questionnaire, but it's also been tailored to Worcestershire Acute, and we've just re-edited. So we get that feedback. It comes back through the bereavement team and the audit team are really helpful. But any voices questionnaires that come back where there is a concern, they will go directly to our end-of-life facilitators, who will make direct contact with the person who has completed that form, and they are asked to leave a contact if they wish to be spoken with. So we will always make that direct initial contact with them, often to understand what has happened, what we could have improved, and then we will go back to that clinical area, to the ward manager, to the matrons, and work together to see how we can improve that, but also engage in that conversation together with the person who has raised the concern or shared their experience.
Thanks. Anna, do you want to add anything to that?
Yes, it was just to add briefly. Hello, Anita. I've developed our partnership with the Worcestershire Association of Carers. So to add to that and to have a way of kind of having an ongoing conversation, we're going to run carers conversations in partnership with the Worcestershire Association of Carers this year, and we'll sort of run that under themes to kind of explore how we can have an ongoing face-to-face conversation as well.
Thanks. Sue Sinclair.
Thank you, Chair. I've only got a tiny question, but firstly, can I just say how terribly impressed I am with all of that, Avril and Paula, because I sit as a medical examiner in another institution. So I speak to a lot of bereaved families, and everything you said is so important and makes such a difference. And when we don't get those things right, it's devastating. I was also incredibly impressed at the breadth of the disciplines and staff roles that you brought into this. It's not just about the nurses and the doctors. The small kindnesses are actually delivered by the very people you had on that video, so I was really impressed by it. My only small question is do you have any method of feeding back? The medical examiners, I assume, are also speaking to bereaved relatives. Do you have any mechanisms for feeding that back in?
In terms of feeding back the bereavement, the voices questionnaires?
Yeah, but it's just a different route, because if they're actually speaking to them about other components of the end of life experience, and I just wondered if there was, I mean, it's been difficult with COVID, hasn't it, to set up new systems, but they're quite an important resource as well, maybe to tack on with what you're doing, possibly.
Absolutely. Yeah, we do have an end-of-life steering group, and we have bereavement representation at that with Elaine Chapman. We have a very good working relationship with both bereavement officers and the MEOs, and we're able to talk to each other very, very openly. And often from the bereavement feedbacks that we all get, or the engagement or concerns we all get on the ward at the time, hopefully we would have been engaged as a team to try and look at what's going on at the time in real time, and hopefully capture those moments where we can. Obviously we can't capture them all, so in terms of that steering group, we do look at bereavement and any concerns. The voices questionnaires are also available on our webpage, our trust webpage as well.
Anna, do you want to add anything to that? No, you're right. Christine.
Yes, so I'm the board executive lead and champion for end of life care, and I attend the end of life steering group, and I would echo what Avril says, that is the place where we triangulate this information. So and if our medical examiners, officers are talking to bereaved relatives and are picking up anything that we can use to improve our support processes, that will be where that is discussed with a view to implementing any changes that we need to make.
Thanks, Christine. Any other questions? No? Okay, well, thanks very much, Avril and Anna, for that. So it is a fantastic video, and you should be proud of it. It really does get the message over really well, and not only the message about listening to people and changing your service in response to that, but also the breadth of the people that are engaged in end of life care. It shows that the teamwork that's necessary after that, and this idea, and the great thing it seems to me about about this initiative is, first of all, it's not some kind of central initiative. Somebody, in the centre hasn't said you must do it. It's the people who are currently delivering the service who have got together and tried to improve it. And that's, such an important thing for this organisation, to get away from the idea that, that everything has to come from the centre, that actually giving people the freedom and the ability to respond to their patients and do the right thing is an important part of what we are doing. Now, I don't know if there's anything finally you want to say, Avril, before I'm sure there is. Yes. So Avril.
I think the one thing that I would like to ask of you is support and assistance in terms of an assurance that parking would continue to be free for those relatives and those carers, because that's the one assurance that haven't been able to, I suppose, finalise, for want of a better word.
Can I just say, Avril, as this is not part of some clever ploy by us, but once you started speaking, the sound went off. So I didn't hear what you said, and I didn't do it on purpose. But there seems to be some problem about network quality. Would you just like to say that again?
Yes. Can you hear me now?
I can hear you now. Yeah.
Excellent. I think the one ask from us in terms of support is the assurance that there is free parking, because that's the one thing we haven't managed to get a total assurance about.
Okay, well, it's an interesting question, and I think Matthew is going to answer it definitively.
Definitively. Thank you, Chair, and well done, Avril, for raising the question. I mean, the overall car parking arrangements for the Trust are obviously going to be reviewed once we're out of this wave of COVID. And I think we'll certainly take into consideration the kind of specific needs of specific groups of patients and relatives, because it's not only those relatives for patients of end of life care. We've obviously got those relatives for intensive care and so on. So I think we'll be very mindful of all of the specific needs of certain groups, and we can make sure. I'm very happy to commit to make sure that we do that and continue that for that specific. We'll just need to work out the process by which we do that, which will come once we review car park in its entirety.
Okay, I see Paul Brennan wants to come in there as well. Paul?
No, I wouldn't dare disagree with Matthew's summary.
Yeah, so does that mean perhaps? I mean, just all you politicians, I don't understand. So it's a fairly straightforward question.
Chair, it's very straightforward. It's a small number of relatives, and I think there's no reason why we can't make that happen.
There you go. No reason why we can't make that happen. It's as probably good as you're going to get, Avril, at the moment. So yeah. I take that.
I'm taking it.
Okay, thank you. Thank you very much, Avril. Thanks everybody for that. And thanks for that very direct question. Good. Okay, let's then move on to items of any other business. I forgot to say about apologies, by the way, at the beginning. I haven't got any apologies. Have we got any, Rebecca?
None that we have received, Chair.
Okay. Okay, any other items of any other business that people want to put on the agenda at the end? No? Good. Declarations of interest, they're on the website, and there's nothing in relation to the business here. Minutes of previous meeting, are they a reasonable reflection? Yes, we agree? Good.
Just one point, Chair. I think when we had discussions around the comms, when comms reported back, because they report on quarterly basis, we had a discussion in terms of how comms could perhaps engage better with communities and diversify its comm strategy. And I remember that the outcome discussion was that you had given a steer for comms to bring back a diversified comm strategy or of something of that sort at their next quarterly meeting, but that's not reflected in the minutes or the action schedule.
Right. Okay. Can we update that and just, but more importantly, just make sure that the action is put down for the next meeting so that the comms report does reflect that. Thank you.
Yes, Chair, we'll pick that up. Also, the YouTube link, we'll update that. We caused a security risk when I put it in, so we'll make sure there's a link back to the website.
Thanks very much. Okay. So, action log, Rebecca?
Action log is as updated. If we can take the log as read, there's updates against the open actions. There's a number that are closed. We've taken an approach of a limited amount of follow-up given the operational pressures at this time. So we'd look to review those in more detail at the next meeting, and if we can take the actions as read.
Thanks very much. Anything on that? No? Good. Let's move on then. The only item I've got to talk about is that, as people will know, if you read the newspapers, local newspapers, and they're on Twitter, work has started on the what's it called? The clinical something. What's the name of this thing?
Clinical admissions
unit.
Clinical admissions unit. Okay. The clinical admissions unit over on oncology. It was important to get on with it. We were given the money to get on with it because the quicker we can get it into action, the better. So I, in the technical terms, undertook Chair's action in accordance with section 24(2) of the Trust Standing Orders to agree that Paul Brennan could sign a letter of instruction to Keir, and that's what I did, and I need your approval for that. Thank you. Very good. Let's then move on to the Chief Executive's report. Matthew.
Thank you, Chair. Good morning, everybody, and Happy New Year if we're still allowed to say that on the 13th of January. My report this month to the board is, I think, dominated by our two key priorities, really, which is responding to this latest wave of the COVID pandemic, and secondly, the need for the planning in through next year and the subsequent 2 years as part of our 3-year plan. But I want to start off again, as in line with your comments, Chair, earlier in the meeting, to thank everybody for their fantastic focus and efforts on putting patients first. Our staff continue to do tremendous work in spite of the significant pressures, and I think we as a leadership team tried to recognise that as best we could. We put in some additional initiatives, if you like, for the fortnight over Christmas, making sure that everybody had access to free meals, and I think that had a very positive impact for staff. They were very grateful, as were the catering teams for the support they subsequently received from us as well. And in my sort of out and about across that Christmas week, I think there was a sense of positivity despite the pressures that everybody was feeling. So again, commend our staff for their amazing efforts in spite of real challenges. In terms of the Omicron variant and the latest impact for the organisation, you've got some detailed numbers in my report there. As of the 7th of January, numbers of inpatients that continue to rise as per the modelling that is referenced in the report today. We have 89 inpatients across the two sites, 14 patients in our intensive care units, 5 of which are COVID positive, and our staffing absence levels are around the 7.5–8% total, with around 3 to 3.5% of those absent staff absent as a consequence of COVID. And we're clearly obviously monitoring that very carefully across all of our clinical services and corporate services to make sure that we can support teams in in being able to manage the work and to continue to provide good services for patients. We seem to be faring better than some organisations in terms of absence rates, but as I'll explain later, the consequence of absence rates in other parts of the system are having significant impacts on our patients. You can see there also a reference to the booster progress and some of our continuing focus on vaccination rates, particularly as in the beginning of February, the 3rd of February is the point at which NHS staff need to have had their first vaccine before entering into the difficult territory of not being able to continue to work in frontline roles and therefore needing to be redeployed if staff haven't had their both vaccines in the designated timetable. So we're continuing to work closely with our staff that have been reluctant to have the vaccine in order to support them through that process with line managers having one-to-one conversations. In terms of the national guidance to help organisations, particularly acute trusts, to be better placed to manage the continuing increase in COVID positive inpatients. You can see there our modelling suggests the 24th of January will be the peak, which is only 10 days or so away. There's been very clear national direction to reduce the number of patients in hospital who have no reason to reside by 50%. Our baseline, at any one point, we have 61 patients on average in our hospitals who don't need to be in our acute hospital beds. And clearly there's a daily focus on trying to reduce that number by making sure those patients are discharged in a timely fashion. I think there's three key issues that the teams really are focusing on. Those patients that don't need ongoing support when they go home, and making sure those patients are discharged as early in the day as possible, and the imminent opening of a new discharge lounge in the main hospital on the Worcester site is expected to improve that. The second key issue is social care package capacity, and we know from social care team that they're still only operating at 60% of the capacity that is required, and absence rates and vacancy rates is obviously a key factor in those patients that need to be at home but need support from social care. And our community services partners, of whom about 15% of the support at home is provided by community services rather than social care, they are operating with 15% absence rates, and therefore that is having a detrimental impact on our ability to discharge patients in a timely fashion into either community beds or into community teams. The consequence of that is that we are continuing to have difficulties with 1-hour ambulance handover delays and patients waiting a long time in our REDs. And our Chief Operating Officer and Chief Nursing Officer are now holding every morning a review of every single patient that is in our beds that doesn't need to be, to ensure that there is a clear plan for those patients to be safely discharged as quickly as possible. In peacetime, as it were, that isn't the kind of sustainable way of working that an acute trust can operate with, but it's required at the moment because of the clinical risks associated with patients that are waiting for an ambulance or indeed being held on an ambulance outside our emergency department. And I thank Paula and Paul for their focus on this, because for those patients that are sitting in our beds, not only do they want to be at home in their own beds and sitting in front of their own TVs, but they also have increased risk of hospital-acquired functional decline the longer they're in a hospital bed when they don't need to be. And then finally, Chair, just to note, the planning guidance for 22-23 came out on Christmas Eve. and our teams are continuing to respond to the requirements that are listed there in my report. There is a challenge, as referenced earlier in the meeting, about helping our teams to be able to commit the time to the process, but I've been impressed by particularly our operational teams' recognition of the importance of developing our 3-year plan, year one of which is obviously the 22-23 element of it. And we're making good progress, if slower than I would like. But I think that's a consequence of the challenges that we face. And then finally, Chair, I know that previously we'd recognised and acknowledged that Vicky Lewis, our Chief Digital Officer, was planning to move on to pastures new. Since then, Vicky and I have worked through what good would look like in order for her to stay, and I'm pleased to formally announce to the board, which I think is in the remuneration report later anyway, that Vicky Lewis will continue as our Chief Digital Information Officer and will help us along the journey of digital transformation for many years to come. So, Chair, back to you. Thank you.
Is it just me that's having problems with sound, or is it everybody?
I've been fine with my sound.
Okay, it must be me then. It must be me. Colin.
Thank you, Chairman. Matthew, in your report you highlight the COVID vaccinations, which obviously is the main focus, but also the fact that we're at 64% on flu. Are we happy with that? Is that about where we'd expect to be?
Certainly not, Colin. I think we've been successful, certainly over the last 2 years, at being able to support our staff to receive the flu vaccine. Up to 90% of the staff groups that are monitored. We're continuing to provide the opportunity for staff to be vaccinated against flu, but it is consistent with many organisations. Flu vaccination rates are lower this year across many acute trusts. Tina, did you want to add anything there?
No, and we have tried everything, Colin, by just doing drop-in sessions to go on all of our sites around lunchtimes, etc. But as we're not seeing the take-up as the last couple of years, and as Matthew said, that's consistent with other peer groups as well.
Okay, any other questions? Anita.
Thanks, Chair. Matthew, in terms of the patients we've got that are COVID patients, are we comfortable that the vast majority of those are community acquired? Are we comfortable that our IPC measures are keeping any nosocomial transmission to a minimum?
Yeah, thanks, Anita, and that's an important question because I know, again, across our peer comparators, comparator trusts, a number of finding that there's a lot of nosocomial infections. Our reports don't suggest that. I mean, yes, there are some patients that are testing positive after 24 days. I think today's report shows that 3 patients on each site, I think, have tested positive after a number of days, despite the regular testing throughout their stay. But that's a smaller percentage, I think, of the total than perhaps some other organisations. But of course, we're as we'll touch on in the integrated performance report, we're being very diligent in relation to infection control, because there are other hospital-acquired infections that are prominent. We need to manage very carefully. We've also been seeing a number of incidental positive patients that aren't being admitted to hospital with COVID-related symptoms, and clearly that's something that is really important, that we continue to test everybody in line with the national guidance. But our nosocomial for COVID isn't as high as perhaps other peer organisations, our data suggests.
Okay, thanks for that. There will be an opportunity sorry, Simon wants to come in. Simon.
Thanks, David. Matthew, on staff who haven't had the vaccine so far with the 3rd of February date approaching, do we have an idea of how many staff are involved, how many staff now are starting to take the vaccine, and what our plan B actually is for those who ultimately refuse, in terms of how we manage that process if some, unfortunately, may yet even leave the trust?
Tina, do you want to?
Yes, please. So we're waiting further national guidance, which is due on Friday of this week, Simon. So that will provide further information around the criteria and redeployment opportunities, etc. So the exact numbers of where we are at the moment, we've got 559 members of staff that we haven't got a vaccination status. That doesn't mean to say they haven't had the vaccine. Of those, 43 are on maternity leave and 22 on long-term sick. We have commenced meetings with the line managers and those individuals, and we've completed about 10% of those. They only commenced this week. Of the responses that we've received to date, over 50% have had the vaccine already, and double vaccine, so we just haven't had that recorded on our system. So obviously the data need to be updated. The 23 people have given other reasons of why they've not yet had the vaccine, and these are due to allergies, concerns about side effects, concerns about fertility, the medical exemptions. They don't want a particular brand of the vaccine. They've got needle phobias, and we've only had one person saying for other reasons so far. So we will continue to be holding those conversations over the next couple of weeks, which will then enable us to categorise those staff and then assess the impact. But what I've also done is set up a group at system level, at ICS level. So we've got consistency in approach across organisations, and also then to how we work together when we come to the redeployment stage, if that becomes necessary, on how we can best support colleagues. So it's work in progress, and the main is waiting for guidance on Friday for next steps.
Thanks very much. Thank you.
Okay, thanks for that. So let's then move on after your report to talk about the Equality, Diversity and Inclusion Charter and then the implementation plan. Tina.
Yeah, thank you, Chair. So first wanted to say that I welcome this, and I see this as a really important part of our culture journey going forward. And just wanted to refer people to the Appendix 2, which is the presentation that's got a lot of the information I want to cover now, but for your reference. And the origin of this charter was through the BAME staff network, and it was something they wanted to develop part of their annual conference. So that's the origins. We then took this out wider into the organisation through other staff networks, the forward advocates, and through the divisional board meetings and to clinical teams. And then this is a version 4 of the charter, so that's a sort of result of those groups' inputs. And it's been further developed to include all protected characteristics, but also importantly from the clinical teams, they felt they wanted to include all types of inappropriate behaviour towards staff, patients and visitors. So this is a version, that's why we've got to this version. This version's been reviewed in addition to the groups I've just talked about, through the Equality and Diversity Committee, through with staff side colleagues, through the JNCC, through the Chief Exec Team meeting, and through the People and Culture Committee on the 30th of November. The status of the document is, to me, it's the sort of framework that we obviously all sign up and commit to, but does need to be brought to life in the organisation. So the slide deck sets out a proposal of how we will do that, and it's no point to me to have what I call words on a bit of paper. It's something that we all need to live and breathe and make it as easy as possible, and for people to feel that they can raise and report these incidents, because we know that we've got an under reporting of these incidents currently, and that when they do raise them, they're supported with those, and we do tackle and hold people to account for inappropriate behaviours from all of those different groups. So happy to take questions.
Thanks, Tina. Can I just understand, has this been through the People and Organisational Subcommittee, and
yes,
to what extent has it got the backing of the various staff groups, networks?
So actually, we've got quite good support through two divisions in particular. So the urgent care, who've obviously got higher incidence potentially of inappropriate behaviours because of the nature of the services they provide, but also the surgery division have been really keen to get involved in this work, and they started calling it No Excuse for Abuse Charter. We've sort of yet to confirm the sort of title that we were taking this forward. So there is buy-in from certain groups within the organisation, but there's a lot more buy-in that we need to achieve going forward, and that's why I think we need to be really clear on the status of it at the moment. So it's come on a journey to get to this stage, but we've still got a journey to go to make sure it means something, and we've got the supporting policies, standard operating procedures, etc., and the behaviours and things around it that we need to make sure that we hold people to account for.
But what about the staff networks?
So the staff networks have all been involved in developing this charter to date, yes.
Okay. I've got Simon Murphy. Simon.
Thanks very much, David, and thanks to Tina. I'd just like to pay tribute to your leadership on this and the passion and commitment that you've shown to it. It's been quite a long process, but we're getting there. But I think that's largely down to your time and effort that you've put into this, make sure that it actually happens. I'm pleased to see that we're covering all the protected characteristics that, although this was perhaps starting out of the BAME network, it's important that all staff networks know that this is something that's relevant to them. A couple of questions. First one is, basically, as you alluded to yourself, how do we turn this into reality? If you're on the London Underground, it's see it, say it, sorted. It's that sort of thing. Is there a process that if somebody sees something, they will know immediately what to do, and it happens? And then secondly, there's reference to positive action, and I know we've been looking at this through the recruitment side of things as well. Again, how has that sort of come to life? Has that been through the appropriate procedure so that it's adopted and it becomes a policy that everybody knows is the policy of the trust and is implemented as such? So, thanks again for everything you've done to get us this far. We know we're on a journey, but there are a few more steps to come. But if you could answer those questions, that'd be brilliant. Thank you.
Yeah, of course. So the first question, it's something we're still working through, Simon. So that no excuse for abuse type thing, like you say, it's a similar sort of strap line so that people recognise it, that it's not appropriate, call it out, and follow the agreed process. That's something that we're working on those two divisions to develop, and because they're really keen to be involved, and we've got a range of people from different staff groups involved in those conversations. But the timeliness of those have been impacted by our response to Wave 4, so we've had to stand down some of the meetings this month, but we've got them in the diary for February onwards. The positive action, we've spent time working with the staff networks, so the BAME, Disability and LGBTQ+, and we're moving to a model of recruitment champions that will initially be involved in all band 8A and above recruitment processes. And we're also taking positive action about applying the same approach we do for the 2 ticks for disability to guarantee candidates an interview if they meet the minimum person specification. So we've got a draft process and policy in place that's working its way through our internal governance processes as we speak. So we'll be going to Trust Management Executive this month.
Okay, Julie Moore.
Thank you. My concerns are not about the sentiments or the content of what's in here, because it's obviously right, but we seem to have invented another process. What's the difference between a charter and a policy? And also, why are these behaviours not embedded within what we've been doing for years around the forward behaviours? Are we saying that forward failed, or why isn't it incorporated as part of that? And what's the difference between this and a policy?
So the feedback from the conversations we've had around the networks wanting a charter was to sort of set out the organisation's commitment, and particularly the board and senior management commitment to this, to sort of stand behind this charter, to be really clear and explicit. So where a policy, so a policy is sort of a way of making sure that's applied consistently across the organisation. But to me, this sets out sort of the framework of what we believe is acceptable or not. And I agree with your point, Julie, around the behaviours, and something that my team are looking at the moment, regards to whether the 4 signature behaviours cover all the behaviours that we feel we need. And we've identified gaps, and this is something that we'll be bringing to a future meeting for discussion.
I mean, to me, it could be that we're making a mountain out of a molehill, because to my mind, and as Simon said, we need something short, sharp and snappy, which is we treat everybody, patients, visitors, staff, with respect, irrespective of background, and whatever that is, and that's summed up. But that should be within, and if that's not within the forward behaviours, then that's a glaring omission. And a policy is something that's enforced throughout the organisation. So I'm wondering about the governance of this and what it really means, and how in the NHS we always manage to make things really, really long when we could have a sentence.
Which goes back to the strapline comment, doesn't it? Yeah.
Okay, Christine.
What I would say is that if this is meant to sort of enhance and clarify the forward behaviours, because it is clearly very closely linked to them. The work together one is missing, but I think that is valuable, because that's about collaboration and supporting one another in the workplace. To me, one way that it could enhance what we've said we will do is to say what we actually won't do, what we won't tolerate, because in the past that has sometimes helped me when I've been dealing with people who haven't been behaving in the way that you might expect. It's not always about you haven't been doing this, it's because you have been doing that, and we have said that we will not tolerate that. Just a thought.
Tina, any response to that?
I think we just pop in, it's more reflections around the link to the signature behaviours, isn't it, and thinking that through. Yeah.
Okay, thank you. Colin.
Thanks. My comment really relates more to the impact of this rather than the mechanism by which we do it. I think it's absolutely crucially important that we do make a very strong statement about non-toleration of any of these sorts of behaviours. What shocked me to a certain extent was the data that we got from the staff survey, which showed 1,600 odd people have been subjected to this sort of unacceptable behaviour. And I hope that in a year's time, say, we're able to have a repeat of this paper and see those numbers significantly reduced. Because if not, then we need to be very serious about doing it in a different way.
Okay. Richard.
Chair, no surprise that as a forward advocate, I would say this absolutely demonstrates the strengths rather than the weaknesses of forward, because we're able to align the behavioural charter clearly to 3 of the behaviours, and the spirit of work together, celebrate together infuses the entire thing. I think this is less, my personal reflection on this is less that this is an admission of failure and more a recognition of this board that we have a responsibility to lead by example, to embrace the forward behaviours in all their spirit, and to demonstrate to all of our staff and all of the people in the communities that we care for that we are absolutely committed to facing up to and addressing intolerance in any form, wherever and whenever it is to be found. And I commend Tina for the work that she's put in, and you know, I'm proud to sign up to it as a member of this board.
Thank you. Anita.
Thank you. So first of all, I mean, thank you to Tina, Richard and the team for having got to this far. I guess sort of building on comments made by Colin and Simon. Yes, the data is shocking, but we also know that there's probably underreporting. And I guess my challenge would be, in terms of going forward, if we really want to improve the culture, we've got to give people confidence that if they do report things, that we will act on it. And it comes back to, I think, to Simon's point about saying, can we make sure that as we do this, that there are some really, really clear ways of how you report it, and some really clear things that will give people confidence that they should take the time to report it, and that if they do, something will happen. Because I think you can have as much process as if you like, but if people are still anxious about reporting things, we're not really getting to the nub of the problem. So I just want to kind of make sure that we think really carefully about how do we give reassurance to anyone, or whether protected characteristic or not, anyone that feels able to raise an issue and have confidence that it's addressed. And maybe some short, easy way of reporting, as Simon suggested, would be a way of doing that, and being able to see an action afterwards.
Thanks, Anita. I'll come back to Tina and Matthew in a minute, but before, I've got Hcas.
Thanks, Chair. I mean, if you look at the slides, the LTC, where this BAME involved in comparison with other groups, or LTC, people with long-term conditions in terms of disabled people, etc. The data, as Colin and Anita said, is shocking, and I agree that it's likely to be underreporting, most likely to be underreporting now. So it is right that we have this, and I welcome this. It is right that we need to focus. Now, I just want to talk about two things really. One is that clearly the policy hasn't worked, because this is, organizations have had policies since 1970s, 80s, etc., and it's seen as just sitting on the shelf and not really working. And therefore, I would imagine that BAME network probably thought we need something more action orientated, more sort of, and they see these charters as being more sort of, action focused. But I think when I look at the implementation plan, it's not really action focused. It's very process driven. I mean, you'll be doing training needs analysis, but what are you going to do with that? So my question really is that this needs to be translated. It needs to be outcome focused. Otherwise, it still be like a policy sitting on, a charter sitting on the shelf, and it's not going to make any difference really, and it'll be pointless exercise. So you need to translate this into an outcome focus with key, KPIs, etc. I mean, so that it becomes real. And I'll give you an example. So you have, you've said that you need to have, people from diverse backgrounds sitting on recruitment panels. It's pointless exercise. You're going to have people sitting on the recruitment panels if those people who are going to make the decisions do not understand what positive action is, do not, are not trained in that. And therefore you've got a BAME person sitting on the recruitment panels who's going to advise the panel to say, look, you should be shortlisting XYZ people, etc. And they're not doing it. They're overriding them. So you haven't empowered those people. You're just having a tick box exercise by just having those people on the panel. So that's just a very basic example in terms of how do you ensure that you really have an outcome focused approach. That's one point. The second really is that this is just one element. As an organization, we need to be at the heart of the community. We need to be part of the community. So that's one. The other is that we need to have within the organization an inclusive culture, compassionate culture. We keep talking about that. The third is that we need to deal with the inequalities that exists, in terms of, health inequalities, whether it's people with disabilities, older people, etc., working class people. As an organization, what is our corporate approach? Where is the strategy on workforce leadership development for everyone? Where is our strategy for addressing health inequalities within communities as an anchor institution being part of the community? So this is just one small, very small piece of work. And I said, earlier that I congratulate and welcome this, but there needs to be a corporate strategy on this so that we can actually take a comprehensive approach to equality and diversity, both for our staff as well as for our communities, and I think with that we need some governance structure in terms of, I'm chair of flexible working group. If we had a committee, a subgroup looking at this, then it can actually really drive this forward throughout the organisation.
Thanks, Hcas. Do you want to respond to that?
If I could, please.
And then if I could ask Matthew to bring it all together for us, that would be good.
Thank you, Hcas. And we do have we call it the IDEA Committee, but it's Inclusion, Diversity, Equality Committee. Julie Moore attends where she can from an ed perspective, but we have got representation from each of the staff networks and wider trusts on that, and it's where we look at our strategy, approach and plan, and the outputs of those discussions are our annual Equality and Diversity report that comes through board, but it also forms an important strand of the people and culture strategy. So ED&I and culture is a couple of the strands within my strategy that we work to. I agree with you around being outcome focused, and I'm very keen for the terms of reference of this group that we'll be setting up to take this work forward, that we do set out right at the beginning the KPIs and metrics and outcomes that we want to achieve through this, and that's reported through both the TME and People and Culture Committee going forward. So it sounds to me from the feedback today that I need to provide more information through both the EDI and People and Culture Committee on the work that we're doing in this arena, so people are clear on it, and I'm happy to do that.
Okay, Matthew.
Yeah, thanks, Chair, and thanks, Tina, and thanks everybody actually for contributions during this conversation, because I think my experience with elsewhere of trying to develop documents, policies, charters, compacts that set out the expectations, the culture of the organisation, and catching all of the various parts of our organisation, the communities within it, the cultures within it on a single side or two sides of A4 is terribly difficult, because there'll always be something that will be missing. But it's the power of the conversation, I think, that is so important in shaping that. And I think there's been really good contributions this morning in showing that actually this is a staging point for us in being able to describe what we mean about what is acceptable and what isn't acceptable. I think Hcas's point about meaningful action, I think, is crucial, because as we've said before, words on a page, policies on a shelf, it's actually the actions of leadership, board members, and our middle managers and our clinical staff that is going to make a real difference. And how we deal with those people that are not able, for whatever reason, to behave appropriately is really important as setting out the meaningful action that makes a difference to people. I think also Tina's point about the wider picture in relation to our people and culture strategy, it's obviously iterative. It links back to the earlier points about our communications and engagement strategy. It's also about how we are an anchor organisation within the community. So this is all, I think, connected, as we know, with the overall approach of the organisation. So I think, Chair, what we should do is to reflect on the conversation we've had this morning. Tina and I and the executive team, with some of the key non-execs that are close to this work, perhaps we come back and have a look at how we shape the words on the page. Staff side are also important, as well as the networks, and continue the conversation. It's the conversation, then the meaningful action that's important here. So that's what I'd perhaps suggest, Chair, if you're happy with that approach, and that we come back in a couple of months to board with the distilling of these conversations and other discussions that are being held.
Okay, let's. I mean, what I would say about all of this, and I'm sorry I have mentioned this to one or two people before. About a couple of months ago, I spoke at the annual conference of the British Association of Physicians of Indian Origin, and it was a fantastic event. But fundamentally, at the beginning of it, a whole lot of people got up and said how terribly they'd been treated by the NHS healthcare organisations. And some really, quite moving testament about the way their experience of being employees in the NHS. And I know we've had similar sessions with our own people. And what they got in response was a load of process, when actually what they wanted was outcomes. And this is the dilemma here, I think, that we substitute process for outcomes. There has to be process, don't get me wrong, but that's only a part of it. So, for example, the reason that we want to put people on to have more diverse panels is because we want more diverse outcomes. We want a more diverse leadership of our organisation. And, if it doesn't do that, it's not doing what it's supposed to do. And so connecting those two things together, the lived experience with outcomes, is critical to this making happen. So absolutely take the point that people are making. But first point is this has to be outcome focused. We have to set out. And I think, fine, a subcommittee can go away and talk about that, but I think the board should sign off what those outcomes are. I think it's so important to us as we take this forward. Secondly, I think the connection with the forward behaviours. I note in the papers that we've got our best people promise, and then we've got a list of things which are tacked on to the forward behaviours. Interestingly, it doesn't have the fourth forward behaviour in it, which is about working together and celebrating together, which you might argue is probably at least as important as the others. So that would have completed it very nicely. And I do think celebrating the diversity of our organisation is an important part of it. So we need to think about how we might connect those two things together in a better way. And thirdly, let's not make a meal of it. Let's not kind of construct a whole set of complexity around all of this. It's relatively straightforward. Let's get some outcomes we can all work around, identify what they are, and then put in place things that will deliver those outcomes. And then we as a board then can make sure that it does. But in terms of the sentiments in here, I think the board are 100% behind all of this. And we will always be restless in terms of making progress in this area, because it's such an important thing for our organisation and for our patients. So thank you for the work. And if you take that ahead, and perhaps if we can have, I know everyone's busy, but nevertheless, I think let's not make a meal of it. Let's have something short and to the point to the board in 2 months' time, so we can get this sorted out. But in terms of the sentiment, in terms of the behavioural charter, I think we would support it as a board, approve it, but with the caveats that I've just identified about outcomes and process. Is that okay? Would people sign up to that? Yeah, thank you very much. Let's then move on to the integrated performance report that's going to be led by Vicky. How very nice to see you, Vicky. I can't see you actually at the moment. and how.
Thank you, David.
All right, how pleased we are that you recanted.
I know, and how delighted I am to be staying with you. So, yeah, thank you very much, David. Hi, everybody. Nice to see you, and Happy New Year for those that I haven't seen. So this is the Integrated Performance Report for month 8, which is actually November. Some time ago, and I think as we kind of go through parts of this report, we will get a more up-to-date position, building on some of the information we've already had earlier on in the meeting. So for assurance, this has been seen at the Finance and Performance and the Quality Governance subcommittees. It has an overall assurance level of 4. That's not moved at all for a number of months, even though there has been some diversions in some of the assurance levels across some of the various KPIs. We've identified 3 areas of concern or highlighting in the executive summary. So that's the recovery and restoration of the elective programme, including the outpatients and diagnostic services, infection prevention control, and I know that Paula will want to come on to talk about the latest information around that and how we're managing those challenges and what due diligence we've actually got in place. And people and culture, and then Tina and Paula will also be talking about the latest position around that, and also the introduction of the twice daily staffing meeting as we go through January and into February. Just in terms of the recovery and restoration programme, actually a couple of bright points to just pick out of there. We actually saw a reduction in our overall RTT waiting list at the end of November from the October period of just over 260 patients. We've seen an increase in our diagnostic capacity as well, and that's been maintained at over 16,000 as a result of our waiting list has reduced in terms of our overall diagnostics piece. And our outpatient performance continues to hold up really well as well, which is good news in the face of what was a really difficult and busy month. Urgent and emergency care, even though not identified in the executive summary, we've got sustained COVID-19 demand as we went through November, and we also had operational factors that impacted our patient flow, with Matthew touched on earlier in terms of discharge capacity. Just specifically to pick out, David, in terms of the cancer performance, we saw a dip in the assurance level on 2-week wait cancer, moving from a level 5 to a level 4. But you will note that 3 of these tumour groups of breast, urology and the lower GI actually received high numbers of referrals in November. And I'll pause there, David, and hand back.
Okay, thanks very much. Shall we just talk a little bit about then the recovery and restoration? This is where Paul says the numbers are not very good, but actually I've got some numbers to hand that are new that make it look even better. Is that what you're going to say, Paul?
Not now, no.
Okay. So
Yeah.
what do you want to say about it?
So, well, I mean, in terms of just the key on the recovery side, so setting aside the urgent care, then I think if you take the position for November that this report relates to, then it is all positive movement. The total incomplete list size is down. The number of patients waiting over 52 weeks is down. The number of 104-day plus cancer waits is down. And the total size of the diagnostic waiting list is down. And all of those have gone down in November, and all previous months they've risen every month. So it's positive in that we've kind of stabilised and pulled down. In terms of pulling figures out of my pocket, then we do have a kind of an initial position for December. So if we look at the April to December period, so that's a month on from this, our elective activity, then our outpatient activity is just under 5,000 new outpatient attendances above the H1 plus H2 plan. Our outpatient follow-up activity, and it is important that some of this is key because we're following up on, key strings of appointments. And that is now showing about 7,800 by the end of December, above our H1, H2 plan. and our day case activity is just over 1,500 above plan. Our inpatient activity is 780 below plan, so our overall elective performance is just under 800 above plan. So again, all those and that's for the full H1 plus the first quarter of H2. So in our language, April to December. So that's all positive. And our overall diagnostic position for the first 9 months of the year is just under 7,500 diagnostic procedures and scans above plan for, again, the April to December period. So there are still fundamental issues, although I've said those numbers are positive. If you actually look, as Vicky said, at the November incomplete list, for example, of 57,664, that is the first time we've seen a drop. But before the pandemic, that figure was 35,000. And again, although we've seen a drop in the over 52 weeks to the 6,882 Vicky's referred to, before the pandemic, that figure was 0. So it's positive, but it's a hell of a long way back to get us to where we were in March 20. And it's going to require a sustained level of increased activity going into 22-23. And that's why it's going to be essential that, forgive me for kind of putting it like this way, but for us as a board and an executive team to hold our nerve on maintaining the elective hub that we've created at the Alex and keeping Kidderminster as a green COVID-free centre, because those two hospitals need to function at full capacity as we move into 22-23 if we're going to get those numbers back to, well, let's be honest, those numbers are not going to be back to pre-pandemic level next year, but we need to make serious inroads into that. Because, as I've said, good news that we've turned the table for once on all our elective indicators and all our elective activities above plan. But we have to, sit back and say we have got 6,800 people waiting over 52 weeks and we have none. So that would be my summary, Chairman.
Yeah, thanks very much. Thanks, Paul. A very measured response. Any questions about the recovery, that element before I get on? I'll go on to infection prevention next. No? Can I just ask the question then about all cancers 2-week waits?
Yeah.
And particularly breast symptomatic. What's the story around that, Paul?
So we've got, as we were aiming to be back up to 90%, if you recall, by October. We'd gone from 5% in May, and we'd got to 77% in September, and then we had a huge increase in referrals. Bigger than we had in the previous spike, and we moved out to an average of between 14 and 16 days. We've agreed a recovery plan, a second one, to respond to this, but that is not going to get us to where we need to be until April. And I expect the figures for November and December to come out around 8 to 14% respectively. But it was a huge hike in referrals, a level, as I said, that was significantly more than we had when we had that push in March 21. And this is not down to the clinical team. They worked incredibly hard and put a lot of time and effort to try and get the performance back up. And if that increase in referral had not have happened, based on where we did get to in September in 77%, we were expecting October to come out at 89%, and we just lost it within 4 weeks because of that increase.
Okay.
And that is acknowledged by our primary care and CCG colleagues.
Right. Okay. It just strikes me that on the 2-week wages for cancer, we're perilously close to the bottom of the league table, aren't we?
Yeah.
So explaining why we're different to everybody else is often quite a difficult one in this regard, isn't it?
My understanding from the discussions with CCG colleagues is that the spike we had on breast referrals was not seen elsewhere in the Midlands.
Okay. Okay. Can we move on then to the infection prevention and control?
Yes, thanks, Chair. So I just thought I'd give you an update as of sort of hot off the press today where we're at. I'll start with COVID and then I'll talk a little bit about C. diff, obviously because COVID is, with the Omicron variant, is uppermost in our minds. And you've heard, obviously, this morning from Matthew that we've got 89 cases. What Paul and I have been trying to do with regards to, as Matthew's also alluded to, is meeting with the CCG and Onward Care Team representatives to ensure that we try and open Avon 2 to COVID capacity, hopefully later today, so that will give us some capacity on this site. We have 6 wards that have got a COVID outbreak. We have got them all open, and that is due obviously to operational pressures and clinical need, but obviously with extra stringent measures in place, and they've all had either DPROC cleans or HPV cleans. We also have 3 contact bays within the Worcester site. At the Alex, we have 1 ward that is a COVID outbreak, which is still open to admissions, and 3 contact bays. There are 23 staff in those areas that are affected by COVID. Obviously, we've got more staff affected by COVID, but that's usually household contacts, and they've picked it up from the community themselves. And there are 10 empty beds across all of those wards, which is 7 wards and 6 contact bays across both sites, with 10 empty beds blocked because of the actual sort of vicinity of those actual beds of where we've had those COVID contacts, to try and prevent further spread. So whilst that sounds pretty awful, actually, given the size of the trust, we're doing really, really well. We're keeping it at bay and just making sure that we're looking at those bays and making sure if we can contain it to a bay, that is the best way to work. And then Paul and I, obviously from an operational perspective, look at where we would work at risk with those bays and making sure that we're not creating any further risk to our patients and our staff. So I'll just pause there for a minute to see if anybody's got any questions on COVID before I just quickly talk about C. diff.
So how many of our COVID patients that we've got in the hospital at the moment were infected inside the hospital?
I'm not sure I have that number to date, because some of these is to Matthew. Oh, hang on, how many, Paul?
6.
6. Thank you. The reason I don't have that data is because I wasn't on the huddle this morning. But also the fact that we, to Matthew's point, there are incidental findings. So yesterday, even in the ED at Worcester, a patient came in with a particular diagnosis. We obviously swabbed the patient and was PCR positive. So again, because we're doing our proper checks and balances in swabbing our patients, we're able to pick them up and isolate them as fast as we can.
Yeah, no, that's good. That's good. Any other questions about COVID? So do we think that the 24th of January, Matthew, is what people are assuming the peak is going to be? Is that right?
It's somewhere between the 24th and 27th.
Right. Okay.
There's a difference between there are 2 peaks. One is the peak of new admissions.
Yeah.
Which is, as Matthew said, the 24th. And the 27th is the estimated date of the peak of the maximum number of patients in the hospital.
Right, I see.
So we're expecting to peak in the highest number of admissions in one day on the 24th, and that flows through to the 27th to the highest number of patients in bed.
Okay. And presumably you're modelling and organising ourselves to get ready for. Oh, I'm sure you are.
Yes.
Yes.
Good.
Yes, we are, Paul.
Thank you for that.
Okay, so just to touch on C. difficile, we've breached our target as of December, and that is obviously due to other issues. We've had a norovirus outbreak on Avon 4, which then you do find incidental findings of C. diff, but also the community issues with regards to, through the whole of the 19 months of the pandemic, the prescribing of antibiotics in the community, and more especially through dentistry, which we are seeing that increased incidence. We've got 2 wards at the moment that are open to admissions, but obviously under close scrutiny, which is Avon 4 and Aconbury 4, with regards to the C. diff outbreak, and we're monitoring that. What we have done through any kind of outbreak discussion through our COVID golden command and control structure is talk about where we need to look at other infections other than COVID, and obviously taking on board where we need to make sure that we isolate those patients when we know we've got those findings, and that we obviously send off samples in a timely manner. Now, isolation is an issue, obviously, because you can imagine we're trying to manage COVID and other infections, norovirus, and to your point about the sort of slow uptake of flu, we've only seen a couple of cases of flu this year so far that have required hospitalisation. So with all of that, the staff are managing absolutely brilliantly with this. Obviously wearing their correct PPE, continuing to do their hand hygiene, social distancing, which as exec team we are monitoring even in the restaurants to make sure that the groups of staff who do want to congregate together to have that socialisation of breaks, we are actually saying they can't. So we are making sure we're monitoring that from the whole perspective of the trusts. So I'll pause there and see if there's any questions on that element.
Any questions? Yeah, only so you know, it's like a 4th dimensional chess thing, isn't it?
Yes.
With boards and people and all that. It's just incredible what people are doing. Absolutely incredible. Simon. Simon?
Do beg your pardon. Always manage to do that at least once in the day. Paul, I was just asking about neck of femur. Was that a blip, that unprecedented increase from 15 to 31?
Is that to Paul?
Is this relating to infection, Simon?
I think it's the increased incidence of fractured neck of femur we've seen. Is Paul on the call?
That was the question, yeah.
All right.
Perhaps we can pick it up outside. That's fine. We'll pick it up outside.
It was the highest number we've seen, I think. And there's no particular reason for it. There wasn't a bus crash or anything like that. And there was, and we haven't really had icy days either. So.
Okay, fine. Okay. Any other questions in relation to the integrated performance report? No. Okay. Well, so we note that. Thanks for the fantastic work people are doing to keep things going forward. Let's move on then to the committee assurance reports. F&P, are you going to say something, Colin?
Yes, Richard asked me to cover whilst he's away. Nothing really to add to the report itself. A lot of the items, particularly the business cases, feature on the agenda for the private board. The only thing I'd like to do really is to emphasise the situation we have with the 3-year plan. It's really extremely difficult. It's been a challenging experience, to say the least, I think, for colleagues getting this to progress because of the need to step down on meetings with divisional colleagues, and an important ingredient of getting the plan sorted, obviously, is having the engagement of those who will have the responsibility to execute it. So the whole process is being considerably braked by the need to deal with the COVID situation. But perhaps we can think a little bit more about that as the situation emerges, in terms of assimilating both the COVID situation but also the requirements of the national planning regime.
Yeah, okay, thanks. Anita?
Yes, thank you. I don't know, Colin, whether you can comment on this, not to do with the 3-year plan, but I wondered if you wanted to comment, you could comment a bit on the financial position generally. I mean, obviously, the data we've got here shows that, you know, we are slipping behind where we should be in terms of expenditure. I guess that's not that surprising, but I wondered whether you had any from your scrutiny about comparisons with other system partners, for example, Wye Valley, and is there anything we can do about it? Like, you know, the worry is, of course, as we all know, is if we allow this to continue, it'll just creep and it'll just get a lot worse. And finally, I guess, what's the system's attitude to it? Are they relaxed about it because they recognise the circumstances we're in, or are we starting to get under any pressure? I don't know if that's for you, Colin, or Robert, but just helpful to get some comment on that. Thanks.
I see Robert's hand has shot up, and he says, "I'll be fair, if I may."
Robert.
Yeah, I think that is a question for me, Anita, as you say. I think there's the in terms of our financial position, actually at month 8 for the H2 plan, we were actually ahead of our submission to the system. So that's a positive position. There are a number of one-offs in there that actually made that perhaps flattered us better. We were 400,000 better than what we'd submitted. The challenges we do have is there's a couple of things in terms of the planning. So there was an assumption within the H2 plan that originally there was an opportunity if the independent sector work that we're doing, which is costing us about was planned to cost us about 1.8 million. If that transferred into a system position, it actually meant there was an opportunity to earn elective recovery fund. That wasn't the final position, i.e. it wasn't transferred, so our cost base may appear to be higher than the plan, so the actual versus the plan will be different. That's something we have to, and we do report that, and we discuss that through the Finance and Performance Committee. So in terms of our cost base, that's broadly where we said it would be. I think the challenges we've got is the resources that we're required to put in, particularly on our bank and our agency, to support the staff gaps and actually for people to do extra work. So I think that's an issue, but these should be non-recurrent going forward once we get over the Omicron issues and impacts on staffing, to an extent at least. So not overly concerned about that. It's more about the impact on the forecast going forward. Is as we've just discussed, it's that challenge around the patient activity, making sure we can do that and actually just ensuring that we put them first. So that's the case. In terms of where we are across the system, we do actually, Colin and myself are at an integrated ICS finance forum tomorrow, so we'll look at that. But the weekly meetings I have for the directors of finance, which fun enough is one today, which of course I'm not at, isn't raising any particular concerns about our position or anybody else's position in the system. We're all there working towards what we said we would do at the end of H2. I think the real challenge is how we're planning in terms of both financial framework and potentially risk sharing going into next year, because I think what we're also seeing is part of our improvements is heavily dependent on flow across the system, managing referrals in, managing discharges out. And that's where we as a system need to make sure that we're working effectively and efficiently, and that will also reduce our cost base. The other aspects of our cost base are clearly we're still continuing to have done quite a lot of work on PCR testing. So that, of course, flows through our cost base and is extra to the COVID cost that we already see. So there's a myriad of variances, shall we say, at H2 and month 8, and we'll see that in month 9 as well. But it's nothing that is glaringly different to what we said or thought for this period. But for going forward, it's about really getting a baseline and working out how we can improve that. That's the key. Is that answer the question?
Yeah, I think that's very, very helpful, Robert. Thank you. Okay, let's move on then to quality governance.
Nothing to add to the. She spends a lot of time on infection control.
Yeah. Okay, thank you very much for that. Let's then move on to safety staffing report, adult nursing.
Thank you, Chair. And I've got on the back of the Safe Staffing report, the quality impact assessment, where I'll discuss with you all now the changes that I've made and the assurance I've put in to mitigate gaps going forward within our acute wards. So just from the Safe Staffing report, which is the November report, it's an overall level of assurance of 5. Fill rates for the RN in November did increase, but that was due to we needing extra RNs within the COVID areas. And our fill rates for HCAs, whilst we've got gaps and a high turnover, there is a fill rate at night, especially for one-to-one care, which we're trying to do through agency and bank. Good news is we've got a second cohort of registered nurse associates due to start in January. And just from a sickness perspective, whilst the sickness is high, and it was in November, obviously that's increasing further, but it's surgery and women and children have the highest sickness rates. And I know that Justine will discuss her sickness rates and her issues within her report once I've completed the QIA. If there's no questions on the actual nurse staffing report, I'll just move on to the quality impact assessment.
Any questions? No, we'll move on then.
Okay, thank you. So, as we've just heard, the Omicron variant is causing issues for us, but we are managing that well. We have got significant staffing gaps within the nursing, midwifery and allied health professional group. So with that in mind, what I've tried to do is make sure that we've put mitigations in place, whilst the regional sort of chief nurses have spoken with regards to, in some areas, not particularly this trust at all, have gone to 1 registrant per ward per shift. So that prompted me to look at things completely differently within the trust. So whilst we had daily staffing meetings, we've now put twice daily staffing meetings in. And over weekend, myself, my deputies and the divisional directors of nursing also hold a staffing meeting with the matron, and I'll explain what the matrons are doing going forward. And this is to enable the on-call teams to then just focus on capacity, and we will take the hold of staffing so that we can, as senior staff, move people around the hospital so that we are safely staffed in all our wards. And as of to date, we have not gone to any ward as 1 registrant per ward per shift. What I've done with the matrons in the interim as a pilot, and this will hopefully feed into Paul's new on-call arrangements when that becomes operational and we come off level 4, is that the matrons will now do an on-site shift 7 days a week, both sites, and that covers 8 till 4 and 1 till 9. They are there to also help with capacity and flow, but also to ensure that safe staffing is monitored across the piece. And that is, we started that on Monday, and the overwhelming response from the matrons is that they absolutely adore it. They are really, it's also to help with their health and well-being. Because, you know, if we haven't sorted the site from a staffing perspective by 9 o'clock when the night shift starts at 7:30, then it's a poor show. So by doing that, that enables them to take off the pressure of the on-call teams, and they can concentrate on flow and capacity. Obviously, given all of the gaps that we've got and we're trying to mitigate that, we still need to manage quality and safety. So we obviously will look at that through incident reporting, complaints, PALs, and obviously our friends and family test. And obviously I took the chair down to medical short stay unit a couple of weeks ago to show the proactiveness, because I was receiving some complaints around relatives unable to get through to wards, and that was causing some distress. So the medical short stay unit with Cassie leading it as the ward manager is that they are proactive and now have a proactive call to the relatives in the morning, and then they follow that up with an appointment telephone call in the afternoon with either the nurse and the doctor or both, or a therapist. And that gives them information of their loved one sitting in our hospital bed and what the plan is going forward. That has actually reduced the number of calls to that area. And we tried it in medical short stay unit because obviously that's a fast-paced ward where some of our patients are quite sick in there. So that has really helped with regards to also not only a patient experience, a relative experience, but also a staff experience. And we're continuing to try and roll that out across all of the wards. Obviously, with regards to the issues of how our staff are feeling, I've also put in a 15-minute, 3 times a week response to Omicron, and that enables me to talk to the ward managers, matrons and divisional directors of nursing to tell them what is going on, not only here internally, but also regionally and nationally, and what is expected of them and how we are expected to behave going forward. And also to give them time to tell me if they feel that some areas are not where they want them to be, and what can then I speak with our exec team and the rest of the wider board about how we support those staff going forward. Obviously, we've put a risk in here around making sure that we've got available PPE, and then also helpline in place to support staff absences. And then obviously, as I've also alluded to with regards to infection control, the exec team are doing regular checks in certain areas to make sure that there is social distancing still going ahead. So I will pause there as a whistle-stop tour of the big quality impact assessment. Colin?
Okay, Colin.
Thanks, Paul. I'm being a bit sneaky here. Can I go back to the earlier part of your report? There was a question I wanted to ask in relation to the turnover rate of HCAs. If that seems to be higher than we expect, have we got to the bottom of it? Are we able to take actions to mitigate that?
Yes, and we are looking at that, and that isn't just our trust, that is a regional aspect. There has been a high turnover and high vacancy rate, which is really unusual. We are finding that even the new recruits we have are finding it quite hard to work within our areas because it's tough. It's really tough in the areas, and some have chosen to move into some of the retail therapy shops so that they can get sort of more money per hour, but also a better working life balance, which they feel is what they would get working in one of our supermarkets. But also the changes to the I can't remember think of the name now. What it is? It's the government funding that they were given to individuals during the first wave that enabled them to have some extra money as an individual family. That was withdrawn, so they felt that therefore then they needed to go somewhere where they might earn some more money. But we're looking at the band 2 and band 3s and seeing what we can do to encourage people to move into a band 3 role and train them. We have gone out and done a mass recruitment, and we've got 90 healthcare assistants in the pipeline. Now we've gone to try and make sure that we do a quick training programme of fundamentals of care so that keeps them on board with what is expected of them in some of these areas. And some of these are young people who have come into a hospital and some of them have seen a death, and that doesn't sit well with them. So we're trying every which way we can. And for this month alone, we've also gone to an agency to make sure we've topped up our healthcare assistants, which we don't normally do.
Okay. Right, thanks. On the quality impact assessment, anything on that? So, Paul, what does it mean? I mean, well, the quality. What should I be taking from it?
Well, I think what you should be taking. I think what you should be taking from it is where we're changing certain practices with regards to obviously doing a pilot with the matrons and making sure that they work over a 7-day service, but also that I have looked at the quality with regards to the changes I've made and what impact they may have from a risk-based assessment, and therefore that will be monitored. Now, whilst Christine and I have signed that off, obviously the board needs to have sighted that so that you can see across the whole of the trust what I'm trying to do to ensure I've got safe staffing during this period of unprecedented rise in the variant.
I suppose what level of anxiety do you think I should have?
I think with what we've put in place now, I think your level of anxiety can be quite low at the moment.
Oh, I don't like the I think I should be. Anyway, okay, Matthew.
Yeah, just to add, I think the other piece, Chair, that we want to make sure that we're cited on is this question of safe staffing on a day-to-day basis, and the reviews that Paul has put in place were very much in response to our executive team feeling really quite worried and anxious about staffing absence levels rocketing in the way they have in some organisations, and therefore us really having to make some quite difficult decisions about service continuity. But it's also in response, as Paul has alluded to, many of our staff who haven't had to self-isolate and haven't been perhaps exposed, are fully vaccinated, feeling a little bit that they're carrying the burden of perhaps some of their colleagues not behaving in a similar way. So giving that information and that sharing of actually what's going on, I think, is helping people to see the wider context rather than just the immediate issues that and patients that they're looking after. And I think this, I would agree that what Paul has put in place, I think, is probably as good operationally as we could have in the circumstances. And that gives us, as an executive team, that assurance that there is focus and grip, not in a kind of just week by week basis, but actually throughout the day. And I think those arrangements are helping us to be confident every morning when we have our exec safety huddle, that we're on top of staffing and we're on top of any new hotspots that are emerging. So I think, to answer your question, Chair, we remain anxious and we remain vigilant, but we feel a greater level of assurance on the basis of what Paul has put in place.
Thanks. Anita?
Just a quickie. I mean, this looks great. Do we have something similar for medics?
Sorry, is that question to me, Anita? We've talked before, I think, about staff wellbeing initiatives we have for doctors. In terms of the staffing huddles, twice daily, we don't have that for doctors, as medical staffing is managed within divisions, because there are fewer opportunities for transfer of doctors between clinical services. It is something that we're keeping under review, and we have had instances where we've been aware of particular hotspots for medical staffing where we've asked other services within the same division to help out, but generally it's managed within service rather than across the organisation as a whole.
That works fine, I think, as long as you've got good escalation policies. Yeah. That's the fear you have in those circumstances. Matthew?
Yeah, sorry, Chair. There was one other point I wanted to make, which I forgot to make. The other important element of the quality impact assessment and the work that Paula and the teams have been doing is that we are talking with our community trust partners about how they can assure us as their partners that they are taking a similar approach to risk mitigation of staffing levels, given my earlier points that some of their team vacancy and absence rates are quite significant, and the impact that has on flow through the hospitals. So I know that Paul is working closely with the existing chief nurse and with the new chief nurse that's coming into the community trust to make sure that they're taking a similar approach to risk mitigation and risk management in relation to community beds and community teams. Thanks.
Okay, thanks very much for that. So we take that for. Sorry, did you want to say anything else?
Sorry, Chair. Just to also inform the board that I have also spoken, as Matthew said, but to the CCG, to the unions, and to the CQC to tell them of our plans. So they were very pleased that we informed them of all what we were doing.
Thanks, Paula. Very good. So we note both the safe staffing report and also the quality impact assessment. Thanks for that. Let's then move on to midwifery.
Yeah,
so Justine's on the call.
Thank you. Hi there. We're offering an assurance level of 5 for the midwifery safe staffing report again. We've had a return to a normal level of activity in November that was very helpful. We were able to maintain our midwife to birth ratio and saw an increase in our fill rates as well, which I think was probably in response to the incentive scheme that Paula negotiated on pay rates, which did have a positive impact, which was brilliant. We did see a slight shift in our sickness absence rates from sort of mid 6% to just over 7%. We women's and children's as a whole is a little higher, and I know that my colleague is working in paediatrics and neonatal because they did see a slight spike there. Obviously, we're talking about November and our current position is somewhat different. I wasn't able to provide you with any acuity data in November because we were training the team on the new acuity tool, and I'm pleased to say that that's embedded into our delivery suite area, and I'll have some data for you in the next report, which is quite encouraging. Obviously, we're talking about our current position as well today. So our sickness rates have increased a little further, and we have been incredibly challenged by COVID over the Christmas and into New Year period, with at times as much as 31 members of staff off in the midwifery and support worker group, which equates to about 15% of our workforce. I'm pleased to say this week we're looking at a figure more around 11 people, which sits at around 5%, which is far more manageable, but we're watching that very closely. In terms of support for the staff, we did a drop-in session just between Christmas and New Year. Paula attended that as well, and that evaluated very well, and the staff wanted some more of those, and I'm meeting with them again on Friday to offer additional support and an availability of an opportunity to check in. In terms of our support staff and our retention around that group, because we also see quite a high turnover in maternity services of our support workers. We've done a huge amount of work with the unions recently in trying to create a midwifery support worker role, which is a band 3 role. And finally, just before Christmas, we were able to agree with that group and the unions a band 3 job description, which all parties were happy with. This will then feed into the apprenticeship programme, which will hopefully retain our staff, but also give them an opportunity then to move on into their nurse or midwifery training in the future if that's what they want to do. So that's what we've been doing around retention of that workforce, and I'll update you with sort of numbers and progress against that as we move into 2022. So I'll stop there and take any questions.
Thanks Justin. Any questions? This is, of course, quite a vulnerable area of staffing. It's difficult to cover it from elsewhere. And I know some places are having real serious difficulties here. And whilst I'm not underestimating the difficulties that you're facing, you seem to be making a really good job of keeping it going. So thanks for all that, and for your midwifery colleagues for all of that. Okay, thanks very much. We note that. Good. Let's then move on to the Remuneration Committee. A couple of things on that. One of them you've heard about. Vicky was unsuccessful in trying to persuade anyone better than her to come and do the job, so she's had to stay. And I wouldn't mean it in that way. We approved a package for a potential stroke consultant. Did we make that appointment?
We did, yes. Subject to the relevant pre-employment checks. Excellent.
The connection between a process and an outcome. Excellent. That's very good. More of that we need to see. Good. Okay. Any other business? There was none notified. Thank you very much. That is the end of the board meeting in public. Thanks everyone for attending. We will reconvene in private session at